Okay, good afternoon, and thank you for joining us for today's CMS Measures Management System public webinar, Measuring What Matters, Improving Obesity Management and Outcomes. My name is Aya Gunny, and I work for Patel in support of MMS. This webinar is just one aspect of MMS education and outreach. I invite you to visit the MMS Hub website to learn more about MMS and how to get involved in quality measurement. Let's go to the next slide, please. Okay, so throughout today's presentation, I highly encourage you to submit questions using the Q&A feature, which is near the bottom of your screen. We'll address questions during the live Q&A at the end of the presentation, and then following the meeting, we'll create a Q&A summary to answer in-scope questions we couldn't get to during today's session. And we can go to the next slide. And so this is just showing you where that Q&A function is right at the bottom of your screen. You can go ahead and type in your questions throughout the presentation, and we will, answer as many as we can during that Q&A segment at the end. Next slide, please. So let's get into today's objectives. So over the course of today's webinar, we'll highlight the need for effective quality measures addressing obesity, share strategies for implementing obesity-related quality measures, examine current barriers to obesity care, and discuss recommendations for next steps for developing obesity quality measures. So to get us started, we're gonna pop up a poll to find out what you think about obesity related measurement and barriers to implementing measures. And so we're gonna leave this poll open for a little bit so that you have time to go ahead and enter your answers. And we can move to the next slide. Okay, so I see people are answering the poll. That's great. So today we're really excited to welcome Dr. William Dietz from the Stop Obesity Alliance and Dr. Tracy Zvenich from the Obesity Action Coalition. We thank you both for being with us today, and I will turn it over to Bill to get us started.
Good afternoon. I'm Bill Dietz from the Stop Obesity Alliance, and I'm pleased to be on this webinar with a number of my colleagues. My presentation is going to cover the prevalence and complications of obesity as well as its costs, turn to the development of measures, and close with review of the Lancet Commission report. Before I do that, I want to introduce Patty because I think it's important to hear directly from people who suffer from the disease of obesity. Patty?
I've lived in a large body my entire life. I've had a lifetime of ridicule, bullying, being put down, being discriminated against, being stereotyped as being lazy or lacking in willpower or dirty or sloppy. Diet after diet after diet. All that shame and blame that I got, I turned it inward. I became my own worst bully. I would say things to myself that were so incredibly negative that I'd never say them to any other person, ever. Weight bias is woven into the fabric of our society, and it's a thread we need to pull out.
So I think what Patty says nicely summarizes a theme that should run throughout our considerations of obesity. So I'd like to begin, as I said, with the prevalence of obesity. And this slide shows the prevalence of obesity in non-Hispanic whites, non-Hispanic Blacks, non-Hispanic Asians, and Hispanics. And you can see that there's a significant disparity. The highest prevalence is among Black females and Black female adults. The lowest prevalence and it's probably an artificially low prevalence, is among non-Hispanic Asians. And the reasons those populations are so low is that they use the same criteria as the adult criteria of BMI. And that's really underestimates the importance of different patterns of growth. That if we corrected the non-Hispanic Asian population for the true prevalence of obesity, it would be much higher. The cut points for obesity in that population are diagnosis of obesity occurs between 25 and 27 units of BMI. A prevalence of obesity is above a BMI of 27. Next slide, please. So the same criteria or the same findings that we saw in the adult population are really somewhat replicated on the pediatric population. If you look at the right-hand slide, you can see that that disparity between non-Hispanic Black girls and Black boys exists. There's still the highest prevalence of obesity among the non-Hispanic Black population. And as the left-hand slide shows, there's a real difference because boys tend to have a higher prevalence of obesity than girls in the pediatric age group. And that's a very consistent finding. Next slide, please. The most prevalent comorbidities of obesity in the adult population, and these are underestimates because it's not a representative population of the United States. Patients with classes 1 through 3 of obesity, almost half have hypertension, about 40% have dyslipidemia, 20% have obstructive sleep apnea, and 23% have diabetes, and 18% have metabolic dysfunction associated with hepatic steatosis. These comorbidities increase with BMI. The more severe the level of obesity, the greater the likelihood of comorbidities. And in general, the studies of adults fail to look at the multiple comorbidities with increasing BMI. So, for example, how many patients with hypertension also have dyslipidemia or sleep apnea or diabetes? Next slide, please. This next slide shows an interesting phenomenon, and I'm going to walk you through it very slowly because it's complicated. So the first element is weight loss. So these are people with employer-sponsored insurance or Medicare, and the degree of weight loss is expressed as a percent decrease. So you can see that at each level, the people on Medicare have a higher cost than people who have employer-sponsored insurance. And that the other observation here is that the higher your BMI, the greater the impact on weight loss is on costs. So there's almost a twofold difference for people with a BMI of 45 who have a 15% decrease in their weight. And you can see here that that cost savings is about $4,000 compared to the group with Medicare who have a 15% decrease, and they have about a $6,000 difference. The next slide, please. So what constitutes a comprehensive obesity treatment? This is something that the Stop Obesity Alliance has focused extensively on and shows the variety of approaches for a comprehensive obesity treatment, beginning with prevention and screening. Intensive behavioral therapy is the bottom line for all of this, with a focus on physical activity, nutrition, cognitive behavioral therapy. And in the more severe cases, you move to pharmacotherapy, bariatric surgery, and weight maintenance. Next slide, please. So the obesity care faces a double burden. First, the kind of environments contribute to obesity are hard to address, so that, for example, the way our communities are designed limits the opportunities for physical activity, and people rely on car use. Likewise, large segments of the population lack access to fresh fruits and vegetables or cannot afford those fruits and vegetables. So and beyond that, there are multiple other factors which affect the levels of physical activity and dietary intake. This slide, however, shows the barriers to addressing obesity care. These include the failure to recognize obesity as a disease, or the lack of familiarity with the diagnostic measures, or the insufficient access to obesity treatment resources, like knowing what to prescribe in terms of a GLP-1 or how to refer to bariatric surgery. The lack of understanding of how increased obesity contributes to disease, or the very prominent role of bias, stigma, and discrimination which leads medical providers to dismiss obesity as a personal failing and thereby ignores the kind of efforts that people with obesity have made over time. And most importantly, I think there's lack of agreement on an obesity diagnosis that is the topic of this webinar. That is use of BMI or BMI plus, which we'll come to in a few minutes. But overall, I think there's a need to recognize that obesity is a disease, not simply a behavioral problem. And all of these factors contribute to as barriers to access obesity care. Next slide, please. So why do we need quality measures? Well, for a number of reasons. Quality measures holds providers and payers accountable, and importantly, what gets measured gets done. So if people document BMI or the degree of obesity, that right away focuses attention. And we know that when providers share the diagnosis of obesity with patients, patients are more likely to initiate weight loss. Quality measures linked to payment. They're the criteria for value-based care changes in BMI. So if you're not measuring BMI, you're not assessing whether the care that you're delivering is making a difference. It monitors the quality of care delivery and it improves outcomes. Also, ultimately, measures can be used to assess the patient satisfaction and to inform consumers. Next slide, please. So what constitutes the criterion for a quality performance measure? Well, it must be meaningful, it needs to be feasible and reliable and absolutely possible to apply within healthcare systems. It needs to be able to assess the variability so that improvements can be monitored, and it needs to be tested so that we're sure that there are no unintended consequences of the diagnosis of obesity. There are a variety of measures of obesity, which include process measures about whether steps were completed, or outcomes, or patient experiences, or structural or composite measures. But our focus, and the most important thing, is that this whole process starts with the diagnosis of obesity and emphasizes the need for a performance measure of a quality measure for the assessment and diagnosis of obesity. And we cover that in just a few minutes in the next series of slides. Next slide, please. So I'd like to turn now to the history of measures of obesity. And these really began in 2008 with the National Quality Forum endorsed obesity measures that were in place up until 2016. And these measures included adult patients with documented BMI, adults with serious mental illness screened for obesity with a follow-up, children who are overweight or obesity based on a parental report of height and weight assessment and counseling for nutrition and physical activity in children and adolescents. So one of the important observations about these measures that were in place for the National Quality Forum in 2016 was that all endorsements of these measures have been removed by the National Quality Forum except for the childhood obesity measure. And that measure itself is flawed because it doesn't specify what the counseling for nutrition and physical activity in children and adolescents is or how successful it is. Next slide, please. There are some measures that are still in place. These include an adult measure for obesity care and screening based on a body mass index, which is part of CMS's merit-based incentive payment system. And they also have a pediatric measurement for weight assessment and counseling for nutrition and physical activity for children and adolescents. NCQA still has a HEDIS measure for children, and CMS Medicaid Child Core Dataset also still has a measure. But notice that there is no measure of BMI or the degree of obesity absent the measures that were previously in place from the National Quality Forum. Next slide, please. So there are a number of efforts underway to assess the availability or importance or validity of other measures of obesity. And this is a study that was done by the American Medical Group Association and published in 2020, actually published in 2021, that looked at operational tracking of the obesity prevalence using BMI and the prevalence of obesity-related complications. They looked at performance measures such as the frequency of the obesity diagnosis or the change in weight over time or the use of anti-obesity medications or the assessment of obesity-related complications, and looked at a number of outcomes like patient-centered reported outcomes and change in the score of these patient-centered reported outcomes. These measures were found to be feasible. They provided value to the participating medical care organizations that were part of this study and demonstrated variation in differences over time. However, these were not implemented before that or after that process. Next slide, please. The AMGA is initiating another effort to understand the quality measures for obesity and quality improvement, and they've enlisted 6 AMGA members to participate over a 9-month period to increase the number of people with obesity who receive a formal diagnosis. So you can see here that there's a need for a measure of the diagnosis of obesity. They're also assessing evidence-based comprehensive care and education on long-term sustainable outcomes. Measures include the prevalence of overweight and obesity and the obesity diagnosis, both of which depend on a measure of obesity. And they are assessing obesity care, such as weight management, prescriptions, bariatric surgery, or other interventions. Next slide, please. So the frequency of assessments of obesity in children and adolescents have been sparse. There were the earlier measures, which I just covered, but there's currently a program underway using Alliance Chicago, which is a national network of community health centers to improve personal, community, and public health through innovative interventions. And they've developed a suggested measure in children 10 years and older, in which pediatricians and other primary care providers should evaluate for a variety of lipid abnormalities or abnormal glucose metabolism or abnormal liver function in children or adolescents with a BMI greater than the 95th percentile. That 95th percentile is a marker for the prevalence of obesity in children and adolescents. And they also add the importance of screening for lipid abnormalities in children and adolescents who are overweight. That is a BMI between the 85th and 95th percentile. So the measure description is in the box on the right. These are patients 10 to 17 years of age who are eligible and receive guideline-based metabolic screening for diabetes, hyperlipidemia, and liver disease. And these are measures for the prevalence of obesity and its associated complications. This has also not gone any further than the work that has been done by the CDC and the Alliance for Chicago data. Next slide, please. So one of the big steps forward was the convening and report of the Lancet Commission on Obesity, which was a meeting of a number of experts on obesity who began to revise the perception of obesity as a diagnosis versus obesity as a clinical diagnosis. The commission recommended the use of a BMI plus as a measure of adiposity, and that plus of adiposity includes waist circumference, waist hip ratio, or waist to height ratio. These are measures that are potentially reflect the virulence of intra-abdominal obesity and causing the complications of obesity. They defined preclinical obesity as diagnosed above, and no organ tissue or body system dysfunction. And the definition of clinical obesity turned on the presence not only of the diagnosis of obesity, but the presence of at least one of 18 different organ tissue or body system dysfunctions for adults, or 30 of those measures in children and adolescents. So for example, the polycystic ovary syndrome worked for both adults and pediatric patients, cardiovascular disease in adults, and increased arterial pressure in children and adolescents. They excluded type 2 diabetes as an independent disease entity and not a criterion for the diagnosis of clinical obesity. Next slide. Now, one of the problems and comments on the recommendations is that BMI plus is a sound measure of obesity. We agree with that. That waist circumference reflects fat distribution as well as adiposity, and adult standards for waist circumference exist. Waist circumference greater than 88 centimeters in women or 102 centimeters in men. However, one of the downsides of this is that there's no provider experience with weight measures in the United States, and those measures would require obesity changes in the coding for obesity. Furthermore, there are no estimates of the prevalence of clinical obesity. So that, for example, over half of adults with obesity have at least one of 18 comorbidities, but only about half of these were among the comorbidities at the Lancet Commission's disease states. Next slide, please. So these measures in children and adolescents are even more problematic. So in the diagnosis of obesity, the Commission did not use the percentile measures for the pediatric obesity, which are widely used based on the prevalence of obesity in kids who have a BMI greater than the 95th percentile. And we published a paper last year showing that BMI alone is a highly specific measure of body fatness, but no pediatric standards exist for waist circumference or waist-hip ratio. The measure of waist to height ratio of 0.5 has been proposed as a measure of morbidity in children and adolescents, but there are no cut points for the morbidities. That is, does a waist to height ratio of 0.6, is that adequate? How many of the comorbidities of obesity does that actually capture? Or do we need a higher waist to height ratio to do that? And as in the adult problem, revised coding for obesity would be required. And in a study that we looked at, the prevalence of 12 comorbidities in pediatric patients with obesity, only elevated blood pressure and steatohepatitis also overlapped with the 13 criteria proposed by the Commission. So there's really a disconnect of these measures with the actual observations of morbidity in pediatric and adult populations. Furthermore, it's not at all clear among pediatricians that the absence of the Commission's criteria for clinical obesity would really change the treatment of pediatric patients with obesity and risk factors alone. Pediatrics is about prevention of adult disease. And regardless of what the presence or absence of some of these complications, obesity treatment should proceed. So in summary, next slide. We still recommend the BMI plus as a quality measure of obesity. This is in accordance with the Lancet criteria. It provides the BMI plus, a measure of abdominal fatness, provides an estimate of body fat. It has a consistent association with risk, with acceptable variation in age, sex, and race, and it assesses body fat distribution. So in summary, there's a lot of work that still needs to be done. But the most important, in our opinion, the most important piece of work that needs to be done is the definition and utilization of a quality measure for the diagnosis of obesity. And we believe that the BMI plus a measure of abdominal fat is that quality measure. Thank you for your attention. It's my pleasure now to introduce Tracy Zavinich, who's the Director of Policy, Strategy, and Alliances in the Obesity Action Coalition. Tracy?
Thank you, Dr. Dietz. Again, my name is Dr. Tracy Zavinich with the Obesity Action Coalition. My organization is the Patient Group. We are dedicated to serving people who live with the disease of obesity. We fulfill our mission through raising awareness, education, providing support, and advocacy. As you can see here, we will be celebrating our 20th anniversary, and I would like to invite you, your family, and friends and colleagues to join us at our upcoming national convention, July 24th to 26th, taking place in the DC area. Next slide. Picking up from where Dr. Dietz spoke about the work coming out of the Lancet Commission, there are a few other obesity treatment recommendations in progress. This year, we are awaiting the full standards for obesity care from the American Diabetes Association. They have released their methodology chapter and a chapter on weight bias and stigma, which OAC was a part of the writing group. Recently, a number of organizations worked together to develop a joint advisory statement on nutritional priorities to support GLP-1 therapy for obesity. In addition, the Obesity Society is partnering with the Obesity Medicine Association to develop updated practice guidance later this year, and the Endocrine Society is working on an update to their obesity pharmacology practice guidance, which is expected to release in the next 2 years. These new evidence-based recommendations will provide the most up-to-date scientific data for clinicians and to help measure developers working in this space. Next slide. Next, we will turn our attention to the obesity treatment coverage landscape and discuss some of the barriers to care that exist across payer types. In Medicare, we find outdated coverage policies across intervention type, including for intensive behavioral therapy and metabolic and bariatric surgery. For obesity pharmacotherapy, there is a coverage prohibition due to statute interpretation under Medicare Part D. Across state Medicaid programs, there is limited and variable coverage for obesity treatments, with pharmacotherapy being the intervention type with least coverage. Under Affordable Care Act plans on the exchange marketplace, Coverage data shows that most plans have exclusion policies for obesity care, especially for pharmacotherapy and metabolic and bariatric surgery. And we find wide variation in obesity treatment coverage among commercial and employer plans. This is because obesity is not included in the standard benefit design. Next, we'll take a closer look at each payer type coverage policies. Next slide. Under Medicare, obesity treatment coverage policies are significantly outdated. Starting from the left to the right, we have the National Coverage Determination for Intensive Behavioral Therapy for Obesity. Under the current benefit, IBT for obesity can only be delivered by a primary care provider, and it can only take place in a primary care setting. As we know, there are other qualified provider types, such as registered dietitians, clinical psychologists, and specialty physicians that could be delivering service outside of a primary care setting. This policy also dates back to 2011. There have been 2 relevant evidence updates from the United States Preventive Service Task Force that can be incorporated, with another one coming. A formal request for revision has been submitted to CMS for this NCD. In the middle, you can see the Part D rule that prohibits coverage for obesity medications. This interpretation dates back to 2003, a time when we didn't have the level of evidence we have today, including multiple FDA-approved pharmacotherapy options. On the right, you can see bariatric surgery decision memo from 2013, plus there is another from 2006. Since this time, there are new clinical guidelines that could be incorporated. In addition, there's the opportunity to update language. For example, we don't use the terms morbid obese or obese anymore, and instead use the new ICD-10 codes released by the CDC last year. The new codes use the classes of obesity, class 1, 2, and 3. Other preferred terms would be severe obesity and using people with obesity. These are people-first language options. There are patient-first language writing recommendations available as resource as well. Updating Medicare policies of focus, as you know, it drives and influences other payer coverage policies. Next slide, please. For Medicaid, last year, the OAC and the Stop Obesity Alliance collaborated on a research project where we assessed conditions of coverage for obesity treatments among all state Medicaid programs. We used a data set for all states' fee-for-service and managed care plan documents. The left stacked bar chart, you'll see the range of coverage that exists by obesity treatment type, including nutritional counseling, intensive behavioral therapy, FDA-approved obesity medications, and metabolic and bariatric surgery. Coverage for nutrition counseling is split. For IBT, the majority of states include limitations to coverage, seen in yellow. For medications, about a dozen states provide some form of coverage, but most exclude, seen in red. And while metabolic and bariatric surgery is covered in all but 2 states, you can see that the majority of states use a variety of coverage limitations and restrictions. Overall, the majority of states have significant barriers and conditions of coverage for access to obesity care. Next slide, please. There are several other federal government programs that offer evidence-based obesity treatment coverage. There is the Veterans Affairs MOVE program, the VA MOVE program, which is a well-studied behavioral intervention-based program. The Department of Defense has a clinical practice guideline for the management of adult overweight and obesity. And the Federal Employee Health Benefit Program also provides coverage for comprehensive obesity care. It is important to recognize that these programs and policies exist. However, there are several documented barriers to utilization and implementation for each program. I won't go into the details here, but a couple quick examples include difficulty in transitioning to higher levels of intervention and complicated prior authorization processes. Next slide, please. While the evidence finds many policy barriers, progress toward access to obesity care is underway. At the federal level, the Treat and Reduce Obesity Act was recently reintroduced. This legislation would correct the policy barriers we see under Part B for intensive behavioral therapy for obesity and Part D for coverage for obesity medications. From the regulatory perspective, a proposed rule was released last year that would have reinterpreted the Part D prohibition on coverage for obesity medications. While that provision was not finalized, public statements by CMS leadership show they remain open to developing a framework for coverage of obesity medications. Next, the state of Colorado recently passed legislation that expands access to obesity treatments for large group plans in the state. And finally, the state of Connecticut offers an obesity management program to state employees. A recent analysis by Milliman showed significant improvements in health outcomes and cost offsets for total savings. So again, we are seeing some progress toward access to obesity care. Next slide, please. When we talk to patients living with obesity, we confirm and validate that the barriers to obesity care are real. OAC annual membership survey data showed that 50% of respondents' health insurance policies fully exclude coverage for any obesity treatment. Over a third of our members have a hard time finding a healthcare provider that can help them manage their chronic disease. And when asked about prescription drug coverage, 42% of patients lacked any coverage at all. This data tells us that real people are struggling to access care for their chronic disease. Next slide, please. We heard from Patty at the beginning of this presentation. Her story clearly demonstrates that weight bias and stigma contribute to the gaps, but also opportunities to improve how obesity care is delivered. It is indisputable that obesity is a disease driven by strong biology, not by choice. Obesity treatment is prevention for other chronic diseases. People living with obesity want to live healthy lives, and Americans want choice and quality in their obesity care. So quality measures for obesity care really do matter. They are an important part of when and how obesity care gets delivered for millions of Americans, for millions of patients. The evidence strongly supports the need for measure development in this space. Next slide, please. I'll conclude by sharing a recent initiative in obesity measure development. OAC had the opportunity to collaborate with the International Consortium for Health Outcomes Measurement on the development of a measure set for adults living with obesity. As you can see, the measure set included domains for physical health and clinical outcomes, well-being, health behaviors, body functioning, adverse outcomes, surgery-specific adverse events, and obstetric and gynecological outcomes. Within each of these domains, there are several components seen on the color wheel. The conditions included pharmacological treatment, non-pharmacological treatment, and surgical treatment in populations of adults age 18 years and above. The publication is expected this year, and information about the measure set and methodology can be found on the ICHOM website. Next slide, please. In summary, there has been tremendous progress in the science of obesity. Standards of obesity care are rapidly evolving. However, we still have a long way to go in improving access to care. Obesity quality measures play an important role. And now is an opportune time for measure development and testing in obesity to fill gaps in care. Our organizations, OAC and Stop Obesity Alliance at George Washington University, are excited about the future of quality measures to improve obesity care. We'd be happy to provide subject matter expertise and collaborate on obesity quality measure development. Thank you.